My name is Stewart Cohen from the law firm of Cohen, Placitella, and Roth in Philadelphia. And on behalf of Traumatic Brain Injury, I'm really excited to introduce Dr. Thomas Swirsky-Sacchetti. I've really been looking forward to this conversation as well. Our topic today is neuropsychology and neuropsychologists. What is that? What is a neuropsychologist?
Well, the easiest way to explain it is to say that as a psychologist, I'm interested in human behavior. And as a neuropsychologist, I'm interested in behavior as it relates to brain function. So my job is basically to assess the brain with a fine-tooth comb. A neurologist is responsible for the entire nervous system. So when they're evaluating someone's brain, they typically have about 5 to 10 minutes to do that. Whereas, because we're using a fine-tooth comb and evaluating every possible thing that the brain does, we take an entire day to do a full evaluation.
And before we jump into the subject, could you give us a little bit of your background? How is it that you became educated and licensed and certified to be a neuropsychologist?
Oh, sure. So I got a PhD in counseling psychology from Temple University, and I worked at Jefferson, where I became interested in mind-body, what they called psychosomatic medicine at the time.
That was Jefferson Hospital in Philadelphia.
Yes, that's right. And that led me to begin to explore the brain as part of the mind-body, question. And so I took additional training and coursework to become board certified in neuropsychology. As a psychologist, you're just licensed to practice, generally, but as a board, the board certification basically allows you to present yourself as an expert in a certain field, such as neuropsychology.
Wait, now you mentioned a neurologist before.
Yeah.
A neurologist is a medical doctor, right?
Right.
And they make a diagnosis of someone having a brain injury in one way or another. Is that right?
Yes.
Right. As it pertains to what you do, can you tell us what the neuropsychologist, as a functional matter, what they do and how that's different from what you do?
Well, we also make diagnoses of brain injuries. We work in tandem, really. I mean, what the neurologist can offer that we don't do are CAT scans or MRIs to look at the structure of the brain. And as we talk about a little bit later, even with mild head injury, there can sometimes be structural abnormalities, which are important, very important to document for the patient's recovery. But we're looking, it's like the difference between structure and function. We're really, as neuropsychologists, we're really about how the brain is working. And what we want to do is we want to look at all of the different regions of the brain, and this is a plastic model, and to come up with what I call pattern analysis, which is which regions of the brain aren't working, and does that pattern of deficits, like if it's here, the frontal lobe and the temporal lobe, if they're not working, that's going to suggest a certain diagnosis to me. So, for example, Alzheimer's might look very different than Parkinson's disease. Different patterns of strengths and weaknesses across all of the functions that we measure.
And we'll get more into that as we get into specific questions. I think you also mentioned psychologists and psychiatrists. How does the work of a neuropsychologist differ from that of a psychiatrist?
So it depends on the psychiatrist, but I would say, generally speaking, the psychiatrists are interested in the biological function of the brain. They're interested in neurotransmitters, the chemicals that the neurons in the brain use to communicate with one another in order to influence or improve someone's behavior. So they're generally dealing with more serious emotional behavioral disturbances like bipolar disorder, schizophrenia, ongoing, long-lasting depression, those kinds of things. They can also be interested in traumatic brain injury because, as you'll find out, traumatic brain injury also has emotional consequences or symptoms. But I'd say that that most psychiatrists are, interested in prescribing medication that's going to help affect behavior from a biological perspective. Now, it's tricky because some psychiatrist friends might take issue with what I just said, because some psychiatrists also do psychotherapy, and if they're more, let's say, analytically trained, like psychoanalytically trained, then they might be interested in looking, not necessarily prescribing medication, but looking at behavior based on the first few years of life and the impact of social and familial factors that affect behavior.
You mentioned that you spend a whole day working on the diagnosis earlier.
Right.
How do you do that? What types of things do you do? And can you explain to us how that helps you to arrive at that diagnosis?
Sure. So some of all of the testing is administered one-on-one. So there's no group administered testing that I approve of anyway. And we can go back to that later. The one-on-one testing, some of it can be done on the computer, and most of it is done with paper and pencil and different materials that we use on the desktop. Paper and pencil would obviously be more for verbally mediated, tasks, but a lot of what we do to evaluate the right brain is puzzles and designs and things like that. So there would be different kinds of equipment like blocks or, different kinds of things that the patient would manipulate to demonstrate a function.
You pointed to the brain before and talked about different areas.
Yeah.
Do different areas of the brain help human beings perform different functions?
Oh yeah, sure.
Could you tell us about that?
Sure. So, there's the right half of the brain and the left half. And generally speaking, the left half is involved with language and verbal skills, and the right side is nonverbal, visual spatial skills. Within each half, there's the frontal lobe, which is the chief executive officer of the brain. It's responsible for executive functioning, problem solving. It gets information from all other areas of the brain, and it decides what to do with it, just as a CEO might do in running a company, right? The temporal lobe is involved with
frontal is the front of the brain, temporal is the back?
Frontal is the biggest section. It's actually 1/3 of the brain mass. It's right. It's this part forward.
And if I can, I don't want to take it out of your hand, but
Sure.
if we turn it like this,
This
would be the
is all the frontal lobe.
Okay.
Yeah, right up to this dividing line. The temporal lobe is this flap right here. It's very important for all kinds of memory, so establishing new memory. The parietal lobe is back here, responsible for visual spatial skills, sense of direction, facial recognition. On the left-hand side, it's involved heavily with language. And then the occipital lobe in the posterior part of the brain is involved with visual function, right?
What about math and music?
Good questions. Those are both. It depends on how you do it. Usually the left parietal lobe is involved with math because numbers are a form of language, so it's verbal. But people who are very, very good at math, who like accountants who can look at a column of numbers and come up with it, they're using their right brain. And that's one of the mysteries of the brain. It's how people who are really, really good at things do them differently by using maybe the other half of the brain. And the same thing for music. Like, I'm not musically trained, so if I were to try to sing a song or do something, I might be using just the left temporal lobe and the left frontal lobe, but trained musicians are using the whole brain. They've found a way through practice and through inborn talent to use other regions that I might not use as a novice.
Okay.
So something happens when you become an expert in something.
So when we're talking about brain function, we're talking not only about individual areas, but also the whole.
Right. That's right. And, a comprehensive neuropsychological battery, we're going to look at IQ because we want to know.
Is this what testing that you're talking about?
Yeah.
So one test is an IQ test?
Yes. Yeah, we probably spend an hour and a half just evaluating IQ, but it's a very refined test. So we're looking at the different kinds of intelligences that we have, not just verbal intelligence and verbal problem solving, but also solving nonverbal visual spatial problems, right? But it's important to know what kind of brain you're dealing with in terms of intelligence, because that's going to help us when we make plans for rehabilitation.
Suppose someone's never had any testing done in their life.
Right.
You meet them after a traumatic brain injury.
Right.
How do you compare how they are today with what they were like before?
Well, that's a good question. And what we know from the IQ testing is that there are certain tests that are called HOLD, H-O-L-D tests. And those tests are tests that, like vocabulary, your word knowledge, things like that, those are very highly correlated with premorbid IQ. Your reading ability, that's very highly correlated with the way your brain was beforehand. And those things are not likely to be affected by a brain injury. So we know, if your vocabulary has an equivalent of an IQ of 110, we know you were an above average person beforehand. And we use that as a marker or a yardstick against which to evaluate the other things.
In addition to IQ testing, what other kind of testing do you do?
So we do, executive function, complex problem solving, and it's in that area that some of the tests are more computer administered because they're more complex.
When you say computer administered, does the person taking the test have to use a computer?
They use a laptop, but generally it's just a matter of them using a cursor to click on a certain thing.
There's different types of brain injury.
Right.
From a severe brain injury down to a moderate brain injury, and then the so-called mild brain injury.
Right.
Does the ability of the person who is being tested and the type of tests that are administered depend on the kind of injury that they've had?
Oh, yeah, of course. Sure. Some of the more moderate and severely brain injured people, can't do some of the tests that we have. So we have to, we're always modifying the battery. What I'm talking about now is a typical battery that would apply to most, mild brain injuries. But we definitely have to eliminate some tests and pull in some other tests when the injuries are more severe. Okay. For instance, some of the people I evaluated are nonverbal. They can't speak. So what are you going to do? You have to eliminate basically half the test and then pull in some other tests that,
I asked you when you were going to play tests other than IQ.
So any good battery should include a measure of IQ. It should include a measure of attention, concentration, and memory. With memory, we probably spend an hour and a half just evaluating that one function, evaluating different ways of taking it in through your ears, through your eyes, even through your sense of touch, processing it on different levels, and then spitting it out, in different ways. So memory is a very complex function, and it's one that's very, very sensitive to head injuries. So we spend a lot of time evaluating memory. Language, similarly, taking it in, receptive language, understanding speech, being able to read, expressive language, writing, spelling, word retrieval, finding the right word to express yourself, visual spatial skills, sense of direction, motor and sensory, from simple motor sequencing skills to the most complex forms of, motor actions involving bimanual coordination. Sensory refers to basically just taking in basic sound, for instance, without it having much meaning, just being able to hear, basic stimulation. Because the brain is registering everything that we take in from all of our senses. So from the bottom up, from basic sensory stuff to the most complex forms of problem solving. And then, the last area is emotional or personality testing, because as we'll find out, a lot of people with head injuries have emotional issues. and personality changes as well. And part of that is evaluating effort. The American Academy of Clinical Neuropsychology has issued position papers stating that, especially with legal cases, but I do it with all cases, we evaluate effort, because how hard someone tries on a testing is gonna affect the validity of the testing. If someone's coming in with an attitude of dogging it, or if someone's very depressed or sleep deprived, and that affects their effort, I need to know that, because I'm making diagnoses and treatment plans based on what I see in the data. So we have tests built in to measure, effort as well.
Are the tests that you use in your profession standardized?
Yes. So
Tell us a little bit about
standardized,
that.
yeah, standardized means that they're administered in the same way, they're scored in exactly the same way, and you are often compared to a normative group, which means that you're compared to someone in your age and educational bracket, sometimes even your ethnic background. Important, obviously, because something like motor sequencing at 74, I'm going to be a lot slower doing this than someone at 20. So it would be unfair to compare me to someone who's 20. I would look really impaired when I happen to think I'm not so impaired.
Doctor, do these tests help you make a diagnosis? And if so, how?
Yeah, so what I had mentioned before about pattern analysis, we're looking for a certain pattern of strengths and weaknesses across all of the different functions that I just referenced. If someone has a stroke, that's going to look different than someone who has multiple sclerosis, and then that's going to look different than someone with a head injury. With a mild head injury, we're looking for information processing speed, because the brain, with a mild head injury, the brain can do most things, but it's doing it more slowly, right? A lot of the tests are measured not only for accuracy, like whether you can get the answer right or wrong, but how fast or how long it takes you to get there, right? So speed is really important. And then the cluster of attention, concentration, and memory, that's typical, in terms of a deficit area for a head injury. And then, as I'd mentioned before, executive function or complex problem solving. Sometimes the information's getting to the frontal lobe, but the frontal lobe gets overloaded and doesn't know what to do with it. The frontal lobe is kind of responsible for output, so that in and of itself will affect processing speed, but reasoning and that kind of thing. The other thing the frontal lobe does is, the frontal lobe is kind of like a mantle that sits on top of the limbic system, which is right underneath it. The limbic system is responsible for emotions. So most of us, when we have like stress or some sort of emotional stimulation, the limbic system sends a message up to the frontal lobe, and the frontal lobe decides what to do with it, So, and a lot of the times, for example, if we're angry, the frontal lobe is the one to help us inhibit that angry expression. If the frontal lobe isn't working well because of a dementia or a traumatic brain injury, those emotional surges from the limbic system go unchecked. The frontal lobe isn't sitting on top of it, and that's when you have people acting out with explosive anger, things like that.
Suppose a neurologist, and by the way, do you get referrals from neurologists?
Yes, that's my primary referral source, actually.
And so that means they're asking you for a consult on a case, right?
Right.
And when a neurologist tells you that he's diagnosed a patient, for example, with what seems to be a long-standing concussion and mild traumatic brain injury for the right frontal brain,
Okay.
that's his or her diagnosis of what the situation is.
Right.
Can you just give us a practical example of the test that you would be running and what you would report back to the neurologist based on that testing, how it would be used by the neurologist.
Right. Well, I would never, not that I don't trust the neurologist's word, but I would never just evaluate the right frontal lobe. I would evaluate the entire brain, because the meaning of whatever I find in the right frontal lobe is going to be dependent on what I find in the left frontal lobe. For example, is what I just mentioned with IQ. If the person has a very low IQ, then a lot of the tests that I administer to the right frontal lobe might seem kind of impaired, but they might not really be impaired for that person. It might just be a reflection of his intelligence. So I would evaluate the entire brain, and I would make sure that I want to know more about the injury, the nature of the injury, and why it was just located to the right frontal lobe, because that would be sort of very unusual for a head injury to be that localized. So I'd want to check out the left frontal lobe, make sure that that's functioning okay. Sometimes I can pick up things that, an MRI scan might show a right frontal lobe skull fracture, and that may be why the neurologist is saying, okay, it's the right frontal lobe, but the left frontal lobe could be equally impaired, or maybe not as much. Because in a head injury, the brain is sitting in a bony skull, right? And there's a thin layer of fluid between the brain and the skull to protect it. It's like a protective flotation device. But in a head injury, what happens is, because of the force, the fluid isn't enough to protect the brain, so it rubs against the skull and it gets bruised. You have a coup, which refers to the primary source of impact, and then the contra coup, because the brain gets shaken back and forth, so it's hitting back here as well. Or it could be like this, rotational injury. So it would be unusual to find even though the skull fracture might be located here, it would be unusual to find a pattern of deficits that's just involving that area.
Okay. So you do additional testing beyond the referral just to confirm in your own mind your diagnosis.
Yes, that's right.
And that's the reason why they're consulting another expert, isn't it?
Sure. The other reason is that they want to know what to do about it. Like, okay, so let's say the neurologist was right, and it is more of a right frontal lobe problem. How is that impacting the person's functioning? Can they go back to work? Should they go back to work part-time? Can we modify the workplace so that they can continue to work, with the right frontal lobe deficit? What kind of brain training or exercises could we institute in that case?